FAVMI presents Unfolding Mental Illness, hosted by Saraswati Suresh.
Hello, everyone. Family's Voice on Mental Illness, FAVMI, presents its 24th episode on unfolding mental illness. We are also the Western Zone of Families Alliance on Mental Illness, FACE-ME, founded by Dr. Nirmala Srinivasan. Through our episodes, we strive to educate and support families about mental health, providing them with resources via experts and lived experience, etc. If you are a family seeking guidance and understanding, we invite you to subscribe to our YouTube channel at favme.in. I am Saraswati Suresh, the host, and my co-host is Dr. Sachin Ganorkar. We are the founders of FAVME, and our topic today is mind-body divide in health settings. When we walk into a hospital, we think of doctors treating our body through surgeries, medicines, recovery, etc. But what about the mind? A patient may heal physically, yet struggle with fear, depression, or confusion. That's where liason psychiatry comes in. In today's episode, we explore to understand liason psychiatry, why this is so important, how mental health affects recovery in hospitals, and what families can do to support their loved one. Let's dive into the hidden side of healing, the mind-body connection. And to guide us through this very important conversation, we are joined by Dr. Sheryl John Senthilnathan. She's a consultant psychiatrist in Hiranandani Hospital, Mumbai, and the Holy Spirit Hospital in Mumbai too. She's a very senior psychiatrist, and she specializes in managing cases related to adult psychiatry, de-addiction, consultation-liaison psychiatry, and stress management. With her clinical experience in working at the intersection of physical and mental health, she helps patients, families, and the medical teams see the whole person and not just the illness. Together, let's explore why the mind-body connection matters in hospitals and how families can play a vital role in recovery. Welcome, Dr. Sheryl. It's
my pleasure to be here.
Absolutely an honor to have you on our show, ma'am.
I'm very grateful that you invited me, and I'm really looking forward to this interaction. And I'm very grateful for the organization because I think family support is the most important in recovery from physical and mental illness, and more so in our patients who suffer from mental illness. So it's really heartening to see that we have an organization which is not only supporting their own individual patients who are at their home, but also as a community, supporting each other. So I'm really glad to be here today.
Thank you, ma'am. So, doctor, let's start with the first thing of understanding what is liaison psychiatry. What are the components, what are the structure, and what is the role of the psychiatry in the entire medical team, and how different is this from general psychiatry?
So, in your introduction, you were talking about how liaison psychiatry is where we are having that interface between physical and mental ailment, right? So when we're talking about liaison psychiatry, it is various scenarios in a hospital setting or an OPD setting where both these things are interconnected. For example, it can be assessing a patient in the emergency ward. So many a times, in an emergency ward of the hospital, you will have somebody who's come with confusion or agitation or aggression or some kind of behavioral component, which the medical team is not completely able to discern that is it because of, let's say, low sodiums, or is it because of a head injury, or is it because of an underlying psychiatric issue. So that's where a liaison psychiatrist or psychiatrist in the hospital comes in, where you assess in that emergency situation, whether it's delirium, whether it's confusion. That's one part of how a liaison psychiatrist will work. Then sometimes in patients who are admitted for a physical ailment or a surgery, and that person already has an underlying psychiatric issue or is taking treatment for that.
Okay.
And admitted for the medical issue, the psychiatrist there would want to come in, intervene, see what are the medications that can interfere with the surgery, that can interfere with the medical condition, maybe fine tune the psychiatric medications. So, a person admitted for a physical ailment, but also has a psychiatric ailment, that's where the psychiatrist there in the licensed psychiatric team will come and play a role. Sometimes patient is admitted only for a physical ailment, right? But during the course of that assessment, the treating physician will feel that no, there is another component of the brain involved. The person has extreme anxiety related either to the medical illness or let's say anxiety for the surgery, or there's an underlying depression which presented with physical symptoms. That's when, a licensed psychiatrist will come into place. So in a scenario where there is an interlink between physical and mental health is where a licensed psychiatry team comes into play.
So the licensed secretary comes when the doctor who's actually treating feels a need for the licensed psychiatrist.
Because like you said, that's a difference between a general psychiatry team and a licensed psychiatry team. Because a general psychiatrist will have in the hospital, you're free to come and approach and see the doctor. But when we're talking about a liaison team, it's always in liaison with somebody else, with the other physicians or surgeons in the hospital.
Okay. So if suppose a person has a mental illness, and is admitted for a certain surgery, so then definitely the liaison psychiatrist will be there in place as a part of the team.
Yes. And there are multiple reasons for that, right? I mean, when a person is admitted for surgery, by itself, there is a lot of anxiety. I remember when I got admitted for surgery, I mean, I was so anxious before the OT. And a vulnerable person who's already having an underlying psychiatric issue, it's always better to get the psychiatrist in the hospital involved before any procedure is done.
Okay.
This is just to make that, recovery from that physical ailment faster.
Okay. And also if there are any medicines which can, create more...
Yes. So what happens sometimes is there is an interaction between two different medications. Sometimes it may be the same drug, but with different names. So it's always better to get the mental health professional to assess the number of medications and the interactions. Many a times a person is admitted, with a particular issue. I can give you an example. Let's say a patient is admitted with low sodiums and very confused. And, we are just kind of correcting the sodium without seeing if there is a causative agent. Maybe it is one of our psychiatric medications which could be responsible for the low sodium. Now, when we give a particular medication, every person will not develop low sodiums.
Correct.
But if that person is vulnerable, and in that list, if we are missing to see that medication which is actually causing the problem. So when a psychiatrist gets involved, you look at the causative factor and then the treatment factor, not just treating blindly.
Okay. So are there any models of liaison psychiatrists in the service delivery?
So nothing that is traditional or earmarked, or we don't have like a hierarchical system that's there here, at least in our country. But what kind of model you can see is whether the model will be an OPD basis liaison, right? So in an outpatient department of a hospital or a nursing home, any psychiatrist would probably get reference from their medical and surgical colleagues, because you're going to the physician with a particular ailment. The physician is assessing you and thinks, no, there is a mental health component. So then the referral will come. So the referral can come like that. It can also work the other way around. I have a patient who's on psychiatric medications, and over the course of the years, I've realized the patient has developed thyroid issues, or let's say developed diabetes. And I will liaison with the physician to correct that. Nowadays, for example, a lot of liaison happens between us and metabolic physicians, because sometimes our medications cause metabolic issues. So when you liaison together, it's basically like you told a whole body approach. We're looking at it from a holistic point of view.
Correct.
So that is an OPD basis. Then is an indoor facility. So indoor facility like the emergency ward or the ICU is where we do see a lot of cross referrals happening. to have that service delivery. So these would be the primary kind of components that are there in the liaison psychiatry team where service delivery happens. But there are many members to the team also.
Okay. Yeah, it's just not one single person. It's a complete unit which is working.
Absolutely.
Yeah, I understand. So, so how does liaison secretary bridge the gap between the mind and the body?
Okay, so I really feel that we should actually now change the narrative a little bit.
Okay.
I don't know whether what I'm going to say is controversial or not, but I just feel that we should stop talking about mental health as health of the mind.
Okay.
And the reason why it happens, why I would want to very strongly advocate and say, let's not talk about it as the mind, let's talk about brain health.
Okay.
Because when we are saying mind, everybody thinks it's this philosophical component which you can't see, which has a lot of spiritual and philosophical components to it. And that I think is a disservice because then our, you won't reach out for help thinking this is something that I can control. But if you look at it from the brain health, this is the brain, like a physical organ in the body, then the reach out for help is more. So the bridging of the gap is understanding the biological model of liaison psychiatry. It's all neurobiology. It is the brain getting impacted, presenting with behavioral components. So when a brain gets impacted, you will present with changes in mood, you can present with changes in thinking, you can present with changes in behavior. And we approach it from a biological component of saying, okay, this is what we are going to do in helping in treating the brain, which is also the most important part of our physical body. So that is, I think, what the liaison psychiatry should look at is the biological model of psychiatry. And we should, as mental health professionals, as NGOs, as physicians, advocate that a lot.
Okay, I really take your take on this. Identifying it as a brain and in the physical organ of your body, rather than just saying it's the mind. Absolutely, your narrative is absolutely something which I shall take it on board. Yeah. So, what are the kind of most common psychiatric issues you actually encounter in a hospital setting, and how do you differentiate between delirium and dementia and things like that, confusion? How do you then sort of create that this is what it is?
Yeah, so when we're looking at it from the lens of a liaison psychiatry team, right?
Yeah.
So for example, a medical or surgical emergency where a psychiatrist is involved is usually when the person is showing some kind of confused behavior. Now, that confused behavior can be because of multiple reasons. First thing that we, like you said, identify whether it's delirium. So let's understand, what do we mean by delirium? So delirium means the person is not oriented to time, place, or person. So the person doesn't know that it is, morning or evening, or is not oriented to a family member, or is not oriented to the fact that the person is in the hospital. He or she feels that I'm in a factory setting, or this is my home, unable to recognize the doctor. And delirium usually happens when there is a sudden compromise to the brain function, consciousness, and multiple reasons. So if there is infection which is untreated, or there is high-grade fever, or electrolyte imbalance, multiple reasons because of which the brain goes into hyperexcitability.
Okay.
And when the brain goes into hyperexcitability, it gets into a fight and flight mode where the person is very agitated, unable to recognize anybody. So that is what delirium is. It's an acute thing, something that happens all of a sudden.
Okay.
And if you compare that to dementia is something completely different. Dementia is a chronic or a slowly progressing illness where there are changes in the brain structure. So that can be, there is shrinkage to, I'm just simplifying it, it's basically atrophy or shrinkage in the brain cell. And one of the most important things that gets impacted, then depending on which part of the brain is shrunk more than the other, is usually memory.
Okay.
So when you see a certain kind of, and everybody calls this age related, it's not age related, but as you grow older, if there is a shrinkage, one of the presentations can be memory issues. But sometimes a person would have perfect memory, but it the frontal lobe, like the part of the brain responsible for control of behavior, shrinks.
Hmm.
Then it's more of unfiltered behavior.
Okay.
I don't know. I can give you an example. So I saw 2 days back there was a family who came and they were very concerned about their mother's behavior, saying that she's talking about how she does not have, and they're very. So the background is they're from a very well-to-do family. The mother has been a very very positive and kind person, extremely helpful. Will always make sure the maids in the house are fed. Will give them an extra roti and everything. But for the last 3 to 4 months the family is saying that she's not feeding the maids. She's hiding the food in the house. She's talking about how they don't have any money. She's talking about her past.
Hmm.
And they thought that, maybe she's exhibiting some kind of underlying trauma of her childhood. And that's why she's talking about all these things.
Okay.
But when we actually evaluated, it's not trauma. This is dementia, where her brain is shrunk. When we got the scan done, we saw it was more of the frontal or the front part of the brain, which is shrinking more.
Okay.
And in that situation, what happens is you become very unfiltered and you will say and do whatever without kind of having a filter mechanism. You can become suspicious of people. So that's dementia. And it's a chronic illness as compared to,
Okay.
delirium. Uh, Other thing that we see in clinical presentations is ICU psychosis. So many a times a person would be completely fine, got admitted, let's say to put a cardiac stent, or got admitted because of an appendix surgery and is in the ICU for some time. What happens in an ICU setting? There is no orientation. You're in a place where there is no sunlight. Sometimes there are no clocks. So your circadian rhythm gets a little confused. And because you're not oriented to that clock, time, they can get confused with time, place, person, or they can get extremely aggressive. They can have hallucinations where they feel sometimes that they are kidnapped and have kept here because they can't orient themselves to that place. So ICU psychosis is also a situation where we would want to intervene. Post surgery, post anesthesia, when the anesthesia wears off, sometimes a vulnerable person can present with behavioral issues.
Yeah. I mean, I just remembered, like last year, my mother-in-law went through a knee replacement. And after she came out from the surgery, she failed to recognize us for a couple of hours, and then, she got back to her normalcy. So I could relate to what you were saying at this point of time. Yeah. So the next question I like to ask is, why is it important to recognize psychological distress early in medical patients? And how does the delayed medical intervention affect recovery?
So let's look at it from again, like us, we call this the stress diathesis
So,
model of any illness. That means a person who's vulnerable, uh, there is an add-on or external stressor, and that person will manifest an illness. Now, so in the same way, somebody who has a chronic illness, let's say like diabetes or hypertension,
hmm,
if you look at the detailed history of that person, we always say that you must try to go right from childhood history to the presentation. Right from when the person is in the mother's womb, sometimes it's difficult to get that history. But from then to now, where we notice number of alerting signs of saying that this person is a vulnerable individual. That means somebody who has had more tendencies to develop allergies, has developed, illnesses quite often as a child. And why I'm talking about that is again because like I told in the beginning, the biological model of illness. So it means that brain of that person is also very, very vulnerable. Any chronic illness, whether it's diabetes, hypertension, thyroid issue, now we know it's more to do with immune dysfunction or an inflammatory process that happens in the body, right? Your own body is not functioning very well, and a lot of that signals are coming actually from the brain. So if you're only going to treat the diabetes and you're not going to look at how that person's brain is functioning, then the diabetes is not going to get in control.
Correct.
And that's what we usually see. Like you'll be having 1 or 2 or 3 medications added on, but we have not taken care of the person's depression. We have not taken care of the person's anxiety. So what happens in that situation? Somebody who's anxious is constantly feeling as if they are in a war zone. And in a war zone, your stress axis is so high, your cortisols are high. So then that's going to impact your sugars, that's going to impact your, blood pressure. So it's important to understand that any kind of brain dysfunction is going to directly impact physical ailments as a manifestation, so they can present. The second thing is it also will impact the recovery from the illness. So we have to address that. Hospitalization. So we see that when we look at it as a whole person approach or a holistic approach, the number of days in the hospital reduce because you're recovering faster. The outcome of any kind of, whether it's surgery or whether it is medical intervention, gets better. And sometimes even outcome in the sense of mortality, we kind of reduce in terms of mortality when we are intervening from the mental health point of view also. Hospital stay reduces it. In turn, what happens? It also impacts economics, right?
Correct.
If your hospital stay reduces, the cost to treatment, the cost of medications, everything will come down.
Correct. And I think that's how one has to function, the holistic way of treatment. It then looks at a larger picture rather than being, micro-oriented into the whole system.
Absolutely. And there are a lot of programs now. I have a close friend who has a hospital in Daisar, and they say that they follow the whole person approach, which is a very unique approach. So anybody who gets admitted to the hospital, a detail, whether it's for anything, a detailed history from the physical, from the mental health point of view, from the spiritual aspect, everything is taken. So then what happens is sometimes the person may not have a mental illness,
Correct.
but even kind of expressing their angst, expressing their difficulties, expressing about their stressors to a person who's listening to them non-judgmentally brings about faster recovery from the physical ailment.
Absolutely.
So not necessary that always it has to be that we are treating the mental illness.
Yeah.
Sometimes the intervention also helps in preventing developing of a mental illness because you have kind of given that person tools before the illness developed.
Yeah. You right at the beginning, you're being able to, nurture them through the right mechanism then.
Absolutely.
Yeah. Okay. So what is managing medically unexplained symptoms? This is what you were trying to explain also, I think.
Yeah. So medically unexplained symptoms is what happens is when a treating primary physician cannot put in the symptoms that the person is presenting into the normal anatomy of the body.
Correct.
So it can be pain symptoms, right? Now, if I'm coming repeatedly to you with knee pain, if I'm an orthopedist, I know what the knee is. I'll get an MRI done, I know. But today I'm coming with knee pain. Tomorrow I'm coming with a headache. Another time I'm coming with a back pain. So the pain is very vague and shifting.
Correct.
So that is why they say, we can't understand. It's not explained medically, but it is explained actually medically from the brain point of view. So we really want to advocate, that, and this is very common in old time physicians where they talk about that the referral to a psychiatrist will be to rule out functional issues.
Correct.
So we actually want to actually scrape this whole thing of saying organic and functional because that does not exist. Everything is organic. The organ is different.
Absolutely.
So if you cannot explain it medically, it means you cannot explain it from your neck down. There is something going on in certain circuit in the brain, and that presentation can happen. So it can be an unexplained migraine. So the person is, I'll give an example, migraine, extreme migraine, not getting better with the conventional symptoms. And when you kind of evaluate, you understand how the person is having anxiety. When you are anxious, like I said, your fight and flight response is active. So your whole brain is hyper alert. That means the circuits in the brain are hyper alert. And that is why it's not allowing the headache to get better. Or even pain symptoms. When there is a dysfunction in the neurotransmitters, your sensitivity to pain will be more. So even if I'm touching here, I will feel more pain because the signals are going like that to the brain.
Great. Hmm.
So what we cannot describe or understand anatomically, but can be described by the brain is what you're talking about, medically unexplained symptoms.
And how does the psychiatrist then play a role in this?
So we identify what are the triggers for these symptoms.
Okay.
So what is the anxiety? Sometimes what happens, it can be a trigger. I'll give you an example. Suppose I am a student who's extremely anxious.
Okay.
And I'm not prepared for my exam, which is tomorrow. Now, I don't have the emotional resilience or the coping skills to tell you as my parent that I can't appear for the exam.
Yeah. Okay.
So the brain then goes into a fight or flight or freeze mode. And then maybe I'll come with, I can't lift my right hand.
Oh, okay. Things like that. Okay.
So an MRI will be done. That's normal. So then there's, okay, this is medically unexplained. It's functional. But this person actually cannot lift the right hand because the brain says that this is the only way that you can avoid this exam. So it's not manipulation or something that they're doing on purpose. We sometimes call it conversion symptoms. That means an emotional distress is getting converted into a physical ailment.
Okay.
So what a psychiatrist does, psychiatrists, sometimes we think we act as spies, We are kind of trying to go into the intricacies of everything, paste those puzzles together, and then come up with a clearer picture. And it's not something which is very easy or can happen in the first go. It takes some time when you have unexplained symptoms to, put the jigsaw puzzle together.
And also the patient has to open up to tell you all this also. So you're asking the right questions.
So it's sometimes because the patient is so distressed, he or she is not in the frame of mind to talk about that stressor at that point in time.
Yeah.
Or many a times the patient even doesn't know that is the stressor.
Correct.
So it is the onus is on us to kind of first reduce the anxiety of the patient, and then we can figure out ways of how to help the person cope.
Yeah. I like the way you said we are like spies. I now hand it over to Dr. Sachin to take it forward.
Thank you, Saraswati. Thanks a lot. I think it was a wonderful discussion, and thank you, Dr. Sheryl, for your description of this topic, and which is very important. Back to the hospital. So we'll just focus more on the hospital setup now. I just wanted to understand, how do you prioritize a referral if you're working in a very high volume general hospital? And how does licensed psychiatry contribute to reducing the length of stay and readmissions?
So the referral system or the thing would be first, whatever is an emergency. So either the first preference would be given if there is a reference that's coming from the emergency or the casualty. The next would be if the person or the patient is in the ICU. That would be the first choice. Within 24 hours, we have to kind of address the issue. A person who's in a ward, usually there is a little bit of a leeway because there are a lot of other people also involved in that care. A 24 to 48-hour window is there to go and see. Though we would want to see the person as quickly as possible, the very fact that if we are able to see the person faster, we can reduce the hospital stay. So ICU and emergency ward will be the first thing that we will see, then followed by the hospital wards.
Doctor. Yeah. So what are the challenges exist in integrating for psychiatric care into general medical and surgical wards?
I think, unfortunately, the biggest challenge is the stigma and discrimination. Even today, we are in 2025, but the biggest challenge is that in that liaison and the stigma and discrimination from everybody involved. So the family members sometimes don't want the psychiatrist to come, not because they don't want the person to get better, because they feel that this person's presentation, why are you calling in a mental health professional, right? So the stigma associated with that psychiatrist coming to the hospital. So many a times They also feel like maybe the person will feel very hurt. So when we go for the referral, they say, please don't tell them that you are a psychiatrist. You tell them that you are my friend or you are another physician in the hospital. And we all usually prefer to say we won't do that because then the first interaction I'm having with the patient is not on a basis of trust. Right? So I think a stigma and discrimination from the family, from the patient themselves, because they don't feel that they have a mental health concern. Stigma and discrimination even from the treating doctors. Because I think, like I told you, now it's where we're talking about the biological model. So many a times, physicians themselves will feel that there is no need, or you can just go and tell us, we just go and counsel the person is not listening. Then looking at it, okay, is this an underlying psychiatric actual issue and the person needs more than counseling? So discrimination from the support staff also. Sometimes because of their lack of awareness and knowledge with the nursing staff or the auxiliary staff. So the biggest challenge even today is stigma and discrimination. The second thing is, I mean, we are now talking, all of us are in a metro city like Mumbai. But most of our patients are all over the country in second and three tier towns, where there is also lack of awareness among the medical fraternity about this holistic approach. So that also poses challenge that the person doesn't get the psychiatric help that they need because the treating medical fraternity is not aware that this could be a problem. Lack of adequate training, that about the mental health aspect. Time constraint. In a busy OPD of 100, 150 for a very good physician, sometimes it is humanly not possible for that person to look at the mental health concerns of the person, right? So with no matter how much of goodwill the person is having and really wants to take care of his or her patient, because of the time constraint, he's not able to understand the psychiatric component or put across that referral. Resource. We don't have psychiatrists everywhere. So that's a challenge, but I think that's changing a lot. I think post-COVID, we realize that sometimes the psychiatrists need not be in the same place. There is tele-psychiatry, there is online psychiatrists. So that is slowly, probably over a period of time, may be able to bridge the resource constraint and challenge. So these are the, most of the challenges that I think that we find in hospital settings.
No, thank you, doctor. I think that's a comprehensive list. Also, what does a good licensed psychiatry service look like in terms of workflow, staffing, and impact?
So there has to be a team in place. So a psychiatrist is a very small component of that team. The team will have a psychologist, a counseling psychologist, or a clinical psychologist. Clinical psychologists play a very important role because many a times, when there are legal issues, ethical issues, we want to check the capacity of the patient, the mental capacity, the assessment for neuropsychological issues. You want to get a detailed assessment of the competency. A clinical psychologist with their scales will play a role. Nursing staff, most important part in a team because they are the ones who are with the patient most of the time. Social worker team, so a medical social worker team who's kind of, trained with psychiatry aspects because not just with the patient, right? Talking to the caregivers, helping them once the patient goes back home, how to integrate those things. So these are all part of the liaison team. Occupational therapist.
So can this be replicated, as you said, in nursing homes and hospitals to scale up and integrate mental health care with physical health? Like you were mentioning that there are shortage of mental health professionals, but can a plan be made to scale up licensed psychiatry in all kinds of setups?
If there's an intent, we can absolutely work around it. So the first, there should be an intent by the person in the hospital that this is how I want to run my hospital setup with a holistic aspect of health, right? So if that happens, you need not have everybody in the team there. Even if suppose you're a very small setup and you just have a medical social worker, who has some training in psychiatry. That person can act as a bridge till you get the psychiatrist in place, or even a counseling psychologist in the hospital. So even if you have one or two people of the team in a hospital, that person can bridge the gap till you get, resources. Now, in a small nursing home, you need not have maybe, like I said, a psychiatrist or a psychologist on board, but they can be on the panel. So depending on the need, an approach can happen. So there is an intent that we are looking at health from not just absence of disease, but from physical, mental, spiritual, dimensions. Then we can definitely replicate it in a bigger hospital with everybody on board, in a small nursing home, maybe with one or two people.
Thank you, Doctor. So we'll now go to the legal and ethical questions. As you were discussing earlier, when is the Mental Health Act used in a general hospital setting? So you were mentioning that there are a lot of things going on with the implementation of the Act. So how do you use this in a general hospital setting?
So according to just to understand what the Mental Health Act 2017, it's a cute, that I think we'll probably have another podcast on it. But it basically, what does it want to advocate? It advocates rights of the patient in an ethical manner that treatment should happen. Right? So it covers all psychiatric care delivered in general hospitals. Especially what we are looking at, the Mental Health Act, is when a person is getting admitted. So whether the admission is voluntary, whether it is supported, whether it's emergency admissions, is where predominantly the MH 2017 Act is coming into play. Or there is admission of minors, it's somebody less than 18 years of old, or there is an admission for capacity assessment. Then the Act comes into play. Now, a patient with a psychiatric illness is admitted, let's say, for a non-psychiatric issue. It could be for infection, it could be for surgery. Then the Act does not really have too much of a role in place, because the person is admitted for a medical issue. It only becomes relevant if the person develops acute psychiatric symptoms during their hospital stay, or if the patient's capacity is impaired and the person is not able to take decisions towards the treatment, whether I should get the surgery done that I need. That's when the Act comes into play. When there is self-harm or harm to others in the form of aggression in a hospital setting is when I think some of the situations where we will bring the MH 2017 Act into play.
Okay. And as a psychiatrist, how do you assess capacity and best interest in a physically ill patient?
So the foremost is the detailed history taking of the patient. So assessing and spending time with the patient, right? And every patient may not need a detailed assessment, but a particular patient where you are trying to assess capacity for a lot of things, a really fine history taking is one of the keys where we'll get a lot of clues. A very detailed mental status examination, taking into consideration various aspects about the judgment of the patient, how much of insight the person has into the underlying medical and the psychiatric illness. A mini mental status examination. We usually take that for capacity, to see the memory, to see the cognitive abilities. So that's how a psychiatrist will evaluate in detail, and that can be done by any psychiatrist. Suppose you have a team and there are legal issues. For example, we're talking about making a will or a testamentary capacity in somebody who has an underlying problem. Then a clinical psychologist involvement is very important to do a neuropsychological battery of tests, where cognitive abilities of the person, the understanding, memory abilities of the person are taken into consideration.
Okay. Can a patient be detained in a general hospital ward under the mental health law?
Yes. So that a person can be detained in a general hospital under certain conditions. One is when the individual is getting admitted, because of the underlying psychiatric problem and does not have the capacity to make that judgment. I don't have an insight that I have an illness, but my illness is causing harm to myself or to somebody else. So for safety reasons, you can admit a person in a general hospital. Now, for that, the guardian or the nominated representative of that person is very, very important. And assessment by a mental health professional. So it's applicable in any registered mental health establishment. So all mental health establishments have to be registered under the Mental Health Act. So if your establishment is established, then we call it supported admission. So a person with a psychiatric illness who is harming themselves or others can get admitted and under the support of the family member or whoever is the deemed guardian with a mental health professional on board. Now, emergency treatment. Suppose we don't have a registered hospital under the law. Any hospital a person can be admitted for a period of 72 hours under the Act. Because we say, okay, it will take that much time to settle down. So it can be admitted under any registered medical doctor or healthcare professional for up to 72 hours, including any general hospital. Again, in the situation where supported admission is required. But if the person is getting admitted to a hospital which is not registered under the Mental Health Act, then that hospital's duty is to inform the mental health authority about the admission, and within 72 hours, once the patient settles, then it's important to transfer the person to a facility where permissions are in place. Even the police can bring a person and admit in a general hospital if they feel, again, if there is harm. Involuntary admission, again, when the person is harming self, harming others, many a times even a person can come and get admitted on his own. There's voluntary admission. I feel I'm having a problem and I come and get myself admitted in a hospital which has psychiatric facilities. And there also, then the Act doesn't have too much of a role. The challenges on the Act are when we need supported admission or involuntary admission.
All right. That was that was a detailed explanation. Coming to personal experiences, how do patients experience psychiatric interventions in non-psychiatric settings? Are they more likely to be relieved, confused, or feel judged?
So mixed, right? It's a really mixed approach. In my 20 years of practice, I have seen that in the beginning, when I started my practice years back, there was always a fear of being judged. They didn't want to see a psychiatrist. And like I told, I would see a lot of people saying that don't tell them that you're a psychiatrist. Just come and talk as a friend. Just come and talk as a counselor. But I think post-COVID, I think COVID has been a really very important game changer for all mental health activities and for mental health movement, I think, all across the world, but I think more in India, where an awareness about the problems with mental health has really boomed up so much. So when I said mixed response, sometimes they are a little reluctant, my experience, when I go, and I always introduce myself as a psychiatrist. Maybe the first 5 to 10 minutes, it is a little difficult for them to really kind of connect with you. But once they know that you are not there, it's a non-judgmental, safe space, then they will definitely open up. And then they feel really relieved. Because after a long time, they would feel that so many of my symptoms are now understood by somebody. Not everybody is not negative. Everybody is saying it's in your head. तुम्हारे माइंड में है, तुम इसको सोच रहे हो उसके बारे में बहुत ज्यादा, इसीलिए ये हो रहा है. And then there is this doctor who comes and says, it's not in your mind. I can understand what you're going through. They really feel, I think at the end of the intervention, it becomes a huge sense of relief. So it may start with a little apprehension by me, the stigma, the discrimination, but then it ends with, I think, a lot of relief that, I'm understood. Very, very rarely it happens that they refuse completely. And we have to respect that too, and we give them that space. It helps because then they go back home and they ruminate over that interaction. And then they realize, okay, maybe there is some way to what the doctor said. And they come back, saying that, I saw you 3 months back. You told me these things. But at that time, I was not very open to it. But now I think I would want to take the help.
No, great. I think that's a very good answer. Uh, how can hospitals become more psychologically safe spaces, especially for people with chronic illness or trauma histories?
So, one is understand the brain better. Uh, to understand the biological model of all illnesses. Third thing is awareness. Look at every person who comes to you from the aspect of not just the anatomical presentation, but also from what could that illness manifest in the patient's ability to cope with day-to-day life. So how it's going to impact the person's mood. How is it going to impact the person's role as a parent? How is it going to impact the role of that person's role as a mother, as a husband, as a father? Because what happens is when I have a chronic illness, it could be cancer, it could be TB, it could be hypertension. Because of my physical ailment, a lot of my role that I need to play in my day-to-day life get compromised. But if my treating physician is able to identify that and say, okay, now let's go, you go and meet this person will add on or help you and be the crutch so you can recover faster. So the safe space will come if one, all professionals, especially medical professionals, get rid of stigma. They do not discriminate against a person who's saying, I want to seek help. I think programs like this, where even family members very strongly advocate seeking help. That you know what, maybe it's nothing. I always say that, I know this is a common thing I give when I give my talks. I say that, if I have having chest pain at 2 o'clock in the night, I'm going to the casualty thinking it's a heart attack. It could be the chole that I ate in the night and just causing gas, but I'm not thinking chole. I'm thinking ki ECG nikalna hai. Right? Because I'm so scared that this is fatal. In the same way, somebody is presenting with mood changes or thought issues or behavior changes. Look at it from that point of view. An early intervention, maybe it's nothing. Maybe it's not a mental health issue. Maybe that this person just needed to kind of talk about various struggles, and the mental professional will probably just give some coping skills to deal with it. So that's how I think awareness and getting rid of stigma, discrimination will help make every hospital or even nursing home, even OPD setup, a safe space.
Thank you, doctor. That was a wonderful explanation and very important, I think, for all of us. So now it comes to us. So how do you take care of the mental health of doctors, of yourself, nurses, and the frontline staff in physical wards? Most of my colleagues actually who actually work say that we need to actually take a drink. That's a reality, or we need to have some addiction to actually stay sane. And so even if forget psychiatry, working in any kind of a acute medical setup. So then, how do we look after ourselves, and how can liaison psychiatry actually help?
A very, very important question. Thank you so much for asking that. Over the last 1 year, if you actually open up every newspaper article, you are seeing suicide by young medical professionals, budding. They have the whole life ahead of them. So many medical doctors. It is because we are so used to, I think we have this God complex that we think that we don't need any help and we're only going to keep on giving. How much can you give from an empty jar? So you have to fill your jar first before you kind of help anybody else. Burnout fatigue, compassion fatigue is very, very known and researched. Somebody who's in acute medicals is constantly working, you're going to get fatigue. So one is understand your limitations. We are not indispensable. You're only indispensable to your family. Very difficult for us to discern that, right? If today I'm not going to the hospital for the next 1 month, or I decide that I'm going to stop practice, there will be another more capable and competent doctor who's going to take my place. But nobody is going to take the place that I have in my family, for my children, for my parents, for my in-laws. So as a medical professional, because right from the time that we choose the field, everybody tells about the nobility of the profession, and how every time the patient comes first. Of course, the patient comes first when you're in the patient setting. But you have to learn how to draw the line. To find balance in imbalance. There cannot be work-life balance. A very famous psychiatrist, Dr. Harishetty, always, would give us this example of, there is never a balance. If I am spending some more time in a hospital, that means I'm taking time away from somewhere else. So be accepting that there is going to be an imbalance, but have a very clear cutoff time from your hospital work, from your OPD work and your homework. You have to find time to sleep properly. You come back home and then because I've worked hard throughout the day, I'm going to binge watch the series. I'm going to scroll through my Insta. So I sleep late, I wake up late. So sleep, extremely important, because sleep is one of the critical factors that impact mental health. Trying to find some form of physical activity to do. It could be that you don't have time, but you could just decide to take the stairs in the hospital 2 or 3 times in a day. Get up in the middle of your OPD and just walk around and come back. So that physical ailment. Eating healthy. I mean, I'm a very poor judge to give that comment. If somebody who knows me will laugh at me, because I've only had breakfast in the morning and now it's 6 because I finished OPD and I came here and there's no meal in between. So extremely unhealthy. But what we need to do at least, and maybe you can, pack some snacks, something that you can at least fuel yourself. So the basics of sleep, food, exercise. Have some hobby that you're doing other than medicine. It could be, I recently saw there was this group of, I think in the IMA, a group of doctors who had formed a band and they were going to perform. So try to find out some hobby that you always wanted to pursue. And maybe once in 15 days, go for a class for that. We always have continued medical education. So I will constantly be attending workshops and things like that related to psychiatry. But can I attend a singing workshop, or can I join a Zumba class, or can I just do line dancing? Something different. Learn to enjoy experiences a little bit. Substance use, very strict no, because like you correctly said, we do see that a lot of times medical professionals feel, okay, let me just have that one drink, or let me just take that one Restil 0.25 in the night so I can sleep better. And over a period of time, that causes a lot of cognitive challenges. Feel free to reach out to your mental health professional colleague who's in the hospital, and they will always keep the confidentiality. Be rest assured. So if you have a mental health profession in your hospital, reach out to that person. Don't feel ashamed to take help. The incidence of mental health issues is 1 in 7 people in India. And that 1 in 7 includes you and me as doctors. We don't belong to some other, vacuum or bubble, not impacted. So 1 in 7 of us as human population are going to be impacted at some point in time. So I could have had postpartum depression. I may experience perimenopausal symptoms. And it's very important for me. I can't say, well, I'm a psychiatrist, so I'm not going to take help. How can I suffer if I feel that I'm going through that? Or somebody around me is noticing that I'm having a change. Then, reach out for help. That will make a huge difference.
No, absolutely. I think also wonderfully said. I think we all are vulnerable, but assuming that we are medical professionals, we feel that we don't need help. And I think that's the first step. And I think your subject of licensed psychiatry is truly fascinating, because you are straddling both the worlds. You're straddling the physical wards, the mental health wards, and there's so much of coordination which you have to do. And what I and Saraswati actually take away is your very good explanation earlier that it should be looked as brain health. And all the spiritual and esoteric connotations which come with sometimes with the mind, I think that will disappear, because you know that you are looking at the brain and there's a behavior change happening with whatever is happening inside. So it's been a very enlightening session, and I hope actually that hospitals start integrating this quickly so that they can address everything very holistically, as you rightly said. So thank you very much for this lovely explanation. And as you said, maybe I think we could have another session on the Mental Health Act when time permits, and you have that you have the bandwidth to do so.
Sure.
Before we wind up, any last few words for our families also?
So I was just want to tell, all the families that you guys are the champions. When a person who comes to a mental health professional is with the patient, is with the doctor or the psychologist for 15 minutes or 30 minutes, the family and the scaffolding that the family provides is the only reason why we have amazing outcomes in mental health in India. I think before we had started the recording, we were talking about, how mental health, really the patients with mental illness suffer, whether it's in the developed world of USA or in the UK, because they just fall through the gaps so much more easily because there is lack of the most important thing, which is family to look out for that person. And here, the family not only looks out for the person, but is, championing for the person's cause. So if even if the parents are kind of sometimes neglecting, there will be an uncle who's in Delhi who's calling up and saying, "No, I think that, he's not behaving properly. You must take help." So we are so close knit, and I think that's the beauty of our country and our culture. So hats off to all of you who are championing that. But most important, like Dr. Sachin was talking about, how doctors must take care of our health. Caregiver burden is very, very important. So if you are not going to be taking care of yourself, then you cannot take care of the people entrusted in your care. So, look out for each other, take out time for your own activities, for your own hobbies. Maybe when you form a group and say, okay, you take care of my father who has dementia for about a day, and I'm going to go to the spa and come back. And I will do the same to you another time. So, that family networking together as a group is very, very important.
Yeah.
So all the best to all of you.
Thank you so much for your wonderful
Thank you.
conversation with you. It was absolutely amazing, Dr. Sheryl, and it was a lot of eye-opener comments which you have made. Something to introspect also. So true.
Thank you so much for having me.
Thank you.
Thank you, doctor. That was wonderful. Thanks a lot.